Thanks. So I'm going to give you our early experience with cone beam CT. You heard earlier from Marcelo with a big experience. So this was developed, it's been around, spinning a gantry around a patient, but it's really the flat panels that allow now the 3D data set to be constructed on the table without having to translate the patient north or south with a 180 spin of the gantry. So with standard IIs, this was not available. With the new flat panel detectors, now you can pretty much get a CT scan on the table. This is the first case I did with it, and when you have the workstation in front of you in the room, you can manipulate the images, but we're just going to show you some static things. But this case, I was about to bail, and we just got this new, this cone beam CT. And what I was able to see, I don't know how well it projects, but this is my quick cross and the marker beads of the quick cross extending all the way up. And as we know and we've seen all the collaterals, you can get lost easily, and you can spin the gantry with LAORA views and lateral, but you can get lost easily. You can go up collateral. So with this technology, it gave me the confidence to see that I was anterior and I was in the right trajectory with my quick cross, and I probably would have aborted it, but we ended up completing the case and successfully. So this is at Jackson. We just got this $5 million one, and I just want to show you. I mean, it's a monster machine. The anesthesia people got to have everything away. You have to have all the tubing cleared. It's a process, and for the team to learn. I put sheaths in both groins, and with the power injector, you need more volume to see everything. But this all comes with experience. We have not had experience with the overlay technique that Marcelo was using, or fusion. Hopefully I'll get there. So I just want to show you this. So this guy's had an old Uden filter, and this actually invented at the University of Miami. It was really the first endovascular procedure was these Moodin umbrellas. So this thing was placed in 1975, and he came in with a 43-year-old cable occlusion, multiple DVTs, multiple pulmonary emboli, this story, these legs, and I told him I'll give you a shot. This was his CT. Here's a Moodin umbrella, and I was encouraged that there were two generous-looking iliac veins to work with. So we gave this guy a shot. This is the original venogram showing the cable occlusion and all the extensive collaterals. You can see how you could easily, your wire could go here, and we talk about these string signs. There's string signs everywhere. So it's easy to get lost, and we've seen stents placed in the vertebral column for misadventures. You want to go above and below, and the whole goal is to line up and connect and body floss. Right here in an AP view is deceiving. It looks like we're well aligned. And those of you who have done these, you notice there's a lot of tinkering, but the idea is you want to get the upper and lower targets as close as you can if you're going to consider a sharp recanalization. Here's the Moodin umbrella. So right here we look well aligned. I'm trying to get a wire in here and tinker around for a while. So this is going to look kind of blurry to you, but again, on the table, you can manipulate at the workstation. But really what this is showing you, I want to show you that here's the aorta, very tortuous iliacs, here's the umbrella, and here I am from above and below, and I'm not really well aligned at all. Got this on the table, the axial views you can get. Here's your AP lateral, and you can see how the alignment is not, we're a little far apart. I always do puff venograms, so you extravasate, you don't trash the field. And then I brought a balloon down from above as a target, and then I used a Calipinti needle to stab the balloon and to advance the wire. But I would not have had the testicular fortitude to proceed with this without the cone beam CT and getting me, close. Then just trying to get this umbrella out with forceps, I started chewing on this thing, putting out silicone, but I started fracturing the strut, so gave up on that. And finally, we just, with bilateral wall stents, we reconstructed the inferior vena cava. As you heard earlier, I don't like to cover the renals either. With wall stents, I like bigger interstices, so I covered the renals with a Z-stent, and the patient insisted that he wanted a filter in place because it was his experience with pulmonary emboli in the past, so I put in a suprarenal filter. Here's a double barrel wall stents on IBUS. So with cone beam CT, I need more experience, and I'd love to get more of these overlay views, but I think it really helps you on the table get a 3D view of where your catheters are and make sure you're in the right trajectory as you're doing chronic total occlusions. Thanks.